This video will demonstrate a dual technique for meniscus root repair with a simplified centralization method. There is growing awareness of extrusion as an element of meniscal root injuries. Meniscal extrusion occurs when the meniscus is displaced beyond the margins of the tibial plateau. Disruption of the meniscotibial ligament has been identified as a primary factor contributing to this extrusion. While precise indications for centralization remain to be fully determined, various techniques have been described in the literature. These can be somewhat complex and technically challenging. We describe a simple and reproducible technique for those surgeons who feel that centralization is appropriate for their patients. The case is a 55-year-old female with an onset of knee pain during activity. The patient did endorse feeling a pop in her knee and subsequently had pain and swelling. A mild effusion and positive medial meniscal signs were present on physical exam. Ligamentous exam was normal. Radiographs show minimal arthritic changes and alignment films display neutral angulation. MRI reveals a medial meniscus root tear with extrusion of the medial meniscus body. No high-grade signs of degeneration in articular cartilage were noted. A decision was made to proceed with medial meniscus root repair and centralization using a dual tunnel technique. Procedure steps are listed here. The equipment and implants used are listed here. The procedure begins with diagnostic arthroscopy. The tear is identified and frayed edges are debrided with a shaver. A curette is then used to create a socket at the proposed root tunnel aperture. A 3 cm incision is made at the anteromedial tibia. An Arthrex meniscal root guide is used to create a tibial tunnel in the proposed root socket. A 2.4 mm drill tip guide pin is used, followed by a 4.5 mm cannulated reamer. The reamer head is retained in the joint with the tip visible, and a shuttle suture is then passed. In this case, the waxed end of an Arthrex fiber stick suture is introduced through the cannulated portion of the 4.5 mm reamer and retrieved with a grasper. The second tunnel is created in a similar manner from the medial aspect of the tibial plateau. The outside aperture of the centralization tunnel is approximately 2 to 3 centimeters medial to the root tunnel. Tunnel location is in line with the posterior border of the MCL, where extrusion is typically maximum. A second shuttling suture is passed. A curved curette is then used to prepare the tibial surface at the far periphery of the plateau in the region of the tunnel aperture. 2 all-inside meniscal repair implants are placed at the meniscotibial ligament inferior to the meniscus. This technique utilizes Stryker air devices placed through the anterolateral portal. These may be placed broadly to capture a significant portion of the meniscotibial ligament to tension it against the prepared tibial surface. The tightened suture tails are not cut, but are shuttled through the centralization tunnel. Centralization is observed when tension is placed across suture tails. A standard root repair is then performed. An Arthrex knee scorpion or similar self-capturing suture passer is used to pass 2 1.3 mm suture tapes in a luggage tag configuration at the meniscal root. These are then shuttled through the root tunnel. Both sets of sutures are tensioned appropriately and are tied over a 15 mm DePuy Mitec rigid loop titanium cortical button. Backup fixation is performed distal to the cortical button with a ConMed Argo 4.75 mm knotless suture anchor. Microfracture of the notch is performed to further encourage meniscal healing. Postoperative radiographs are shown here. The patient is made non-weight bearing at the operative extremity for 6 weeks. A hinged knee brace is worn at all times and locked in full extension when not performing range of motion exercises. Active non-weight bearing extension exercises to maintain knee strength and reduce muscle atrophy are instituted. During exercises, range of motion from 0 to 90 degrees is encouraged. Thank you.